But, today we're gonna cover, chapter 7 of other retinal vascular disease for a mixture of either cases, some teaching points, as well as some OPAT board style questions to kind of keep you on your toes. And a lot of the images that you'll see are courtesy of Retina Gallery website, so courtesy of Dr. for help curating a lot of those images. And we'll just go ahead and get started. I do want this to kind of be as interactive and collaborative as possible, so feel free to interject, make commentary or whatnot as we go along. As we try to kind of crowdsource our information together to go through this topic. And so we're in,
See, it sometimes works and sometimes it's fussy. Hold on the screen. Now try.
so we're in April now, so we have first year, second year. We have first years here at all? No?
Like PGY2?
Yeah.
Yes.
Yeah.
We also have an intern.
Okay, I like the answer.
Yeah, they catch up. Oh, Tim, it's another Tom.
Yeah,
And you're gonna be ophthalmology next year, right? Because everything's combined now.
Right.
Yeah.
great. And so, either an intern or a PGY2, seen the floor scene before and just, keeping it as simple as possible. Is this normal or an abnormal floor scene?
Abnormal.
Abnormal. Anything in particular that you see that's abnormal about this?
Some dropout, like temporarily, and then the leakage, or I don't know, occlusion or leakage.
Okay. Okay, so if you didn't hear her, she's describing this area here of capillary dropout and leakage. How about a second or third year, kind of tell me what those findings of that peripheral kind of capillary dropout and leakage is most indicative of, just in kind of broadest terms from a mechanism standpoint.
Ischemia.
Ischemia, correct, okay. And even further than ischemia, what do we see beyond ischemia when it becomes really severe? Proliferation, okay, perfect. Okay, so just in broadest terms, kind of what would you guys throw up as a couple of your differential diagnoses as far as peripheral retinal neovascularization? You can kind of go as dark as possible.
Virtual people, you can answer too.
Sickle cell retinopathy.
Yeah, spoiler alert, right? Yeah, and so this is
Exactly, funny, hold on, there you go. Try that, advancing. There we
just want to
go.
go back, okay. So, as you can see, this differential is pretty vast. It includes everything from your ischemic diseases and conditions that we just kind of mentioned as far as sickle cell to things such as inflammatory causes and even your more masquerade syndromes. Now it's just kind of
5 different controls.
so if you recall in sickle cell retinopathy, the normal hemoglobin A alleles are replaced by mutant hemoglobin S or C. This mutation is due to a single amino acid substitution on the beta polypeptide shape of hemoglobin. That small alteration can lead to a change in the shape of your red blood cells that end up causing sickling, low solubility under low oxygenation conditions. And this kind of triggers an intravascular ocular disease that does result in thrombosis, hemolysis, and hemostasis. A lot of what we'll talk about today will focus on kind of the peripheral manifestations of that, in which we can see neovascularization, but actually most patients who are symptomatic for this actually present with a more posterior involvement where we see occlusions perifoveally and they have vision decrease.
Did it work?
Okay, I think. All right, so quick check-in question for the residents. Proliferative retinopathy and sickle cell is most prevalent in which type? How about ASC? You guys are too smart. So yes, you are correct. It's hemoglobin SC that is the most common form of proliferative sickle cell retinopathy. Non-proliferative sickle cell retinopathy has several hallmarks that have hemorrhagic etiologies. First, starting off with the salmon patch hemorrhages that you see above there, which are a direct result of chronic intraretinal hemorrhages that occur at the site of retinal artery occlusions. You can also have refractile deposits, which are these areas of resorbed hemorrhages that have hemosiderin accumulation underneath the ILM. And finally, like you see below here, we have sunburst lesions, which are areas of RPE hyperplasia, hypertrophy, often associated with hemorrhages as well. Proliferative disease is characterized by CFAN neovascularization, which is essentially an area of peripheral neovascularization, which is since kind of infarcted. It's described to be most analogous to a species of sea coral. And as we mentioned, the highest prevalence of proliferative retinopathy occurs in SC disease compared to SS versus S thalassemia, which is somewhat paradoxical because it's in SS that we see some of our more severe systemic consequences or manifestations of sickle cell. It's been suggested that SS has a more accelerated form of ischemia, which then leads to infarction, whereas SC has a more kind of insidious onset in nature to it, allowing for a greater amount of red blood cells, contributing to lower solubility overall. And this allowing the neovascularization essentially more time to cook and form. Even conditions as innocuous as sickle cell trait can even exacerbate neovascularization and conditions that already have ischemic comorbidities. And of course, our typical management includes the usual retina approaches such as laser photocoagulation and vitrectomy. So moving along here, vasculitis is typically characterized by perivascular infiltrates and sheathing. We can typically see vasculitis in veins prior to arteries. And it's interesting because it can start with inflammation, but it does often progress into hemorrhagic or tractional consequences. And it even can resemble chronic thrombosis and embolus, and so without any inflammation whatsoever. And so it's important to rule out cardiac valve disease, arrhythmias, and hemoglobinopathies in these patients as well. And then it can also be part of syndromes like Sussek syndrome, where we see patients with strokes, deafness, and artery occlusions. I think it's helpful when you're forming your differential to try to group the forms of vasculitides based on the type of vessels that are most predominantly involved. The arterial ones I like to call most of your acronym ones, such as the ARNs, the forms, the Irvan, even lupus SLE, if you think that counts. Whereas vein involvement typically occurs with tuberculosis, sarcoidosis, and Eales. And then finally, we see both arteries and vessels involved in frosted branch angioitis and toxoplasmosis, as well as Crohn's disease. This is a montage photo of a patient with lupus retinopathy. You can see the diffuse intraretinal hemorrhages, almost Roth spot-like in appearance, along with these areas of kind of these distal portions of vascular sheathing here, which is further accentuated on fluorescein angiography. So moving on to a case, a 27-year-old male with sudden loss of vision in his right eye. Visual acuity is 2800 with no past medical history and negative workup. You can see on exam, this patient very clearly has a vitreous hemorrhage along with area of associated neovascularization of the disc, as well as this area of kind of a neovascular membrane in the periphery. And this is further confirmed on fluorescein angiography, where we see leakage consistent with both neovascularization elsewhere and neovascularization of the disc. So this gentleman with the idiopathic occlusive vasculopathy was diagnosed with Eales disease. It's something that we typically see in males that are 14 to 29 years old that present with vitreous hemorrhages and systemic complaints like constipation, headaches, epistaxis. It's largely considered a diagnosis of exclusion in the US. We don't really see it much in developed countries, but it is very prevalent in India, where we see it in about 1 out of 250 eye patients, where they also characterize it as a syndrome involving periphlebitis, ischemia, and neovascularization. The natural history of the disease essentially starts off with vascular and venous inflammation that turns into perivascular clustering. The overall and chronic venous insufficiency and ischemia does end up leading to neovascularization at the sites of the venous occlusions. Overall, the vitreous hemorrhage and the neovascularization are often replaced with glial tissue and then can result in tractional retinal detachments as well. And this perpetual cycle continues until we eventually see either some sort of form of circulatory stabilization or just chronic hemorrhaging again and again, or retinal detachments, of course. So, a suggested mechanism of Eales disease is that it's due to a tuberculin hypersensitivity, which causes an allergic vasculitis. However, this is only supported by a small handful of kind of histopathological studies and case studies that are somewhat conflicting in nature. For instance, one of the larger kind of case series of this, we saw a high incidence of PPD positivity in the Eales patients in 1948 and 58. But it's also worth mentioning that This was the age of the introduction of the BCG vaccine, and so in places like India, and so, up to 67 to 90% of healthy adults in India did have positive PPDs. One case series actually did examine, one of the more well-designed ones examined both the humoral and cellular response to tuberculin and 56 patients with Eales disease and then 50 age-matched controls. And it found that there was no statistical difference in both the ELISA testing or the PPD testing for Eales disease, even further calling that association into question. So we would recommend that you treat the underlying cause for this. Corticosteroids are always good when you have active vasculitis. Laser is always great for the proliferative stages, and then vitrectomy, of course, reserved for your more serious consequences, with the possibility of using anti-VEGF as an adjunctive therapy. So back to our patient that we described before, the 27-year-old that presented with these findings. He had inadequate visualization for laser. He received an injection, and then 2 weeks post-laser, he was 20/30, and you can see a nice, resolution of the vitreous hemorrhage as well as regression of the neovascular membranes, which is also confirmed on the fluorescein angiography as well. So another pop quiz question: which condition is not more commonly seen in males? Is it Coates disease? Is it X-linked retinoschisis, Eales disease, Mactel type 2? Over two for that, and CSR. Very good. Well, if you guessed Mactel type 2, you are correct. So macular telangiectasia is characterized by capillary wall dysfunction in the juxtafoveal region, leading to exudation and vision loss. There are three major types of Mactel. There's type 1, which is referred to almost as macular coats, because of the accumulation of succinate exudates that can almost form something that resembles almost like a lipogranuloma. It's typically seen in young males, and it can be congenital or acquired. And then type 2, as we mentioned, has no gender predominance. It's typically bilateral, seen in the 5th to 7th decade. These patients often have a loss of retinal transparency, blunted foveal reflexes, crystal deposition, also ectatic capillaries and blunted venules as well. They can also have the temporal thickening of the retina with gliosis, and they can also have RPE migration as well as CNV. Also, incidentally, about a third of these patients do have abnormal glucose tolerance tests. Finally, type 3 involves bilateral of the eyes with loss of parafoveal capillaries, and then we can use anti-VEGF in these patients and when they do develop subretinal CNV. This is a characteristic OCT of Mactel, and you can see those almost cystic retinal voids that are characteristic of it without any thickening or edema present. Also, you can see pictures of kind of that pigment clumping that often occurs in Mactel as well. And then a more subtle thing that a lot of people don't talk about is that you can see an increase in hyperautofluorescence foveally in these patients, and that's just due to the migration of the macular pigments. So that's kind of a diagnostic sign for Mactel. So moving on to cystoid macular edema, we all know that results from the increased retinal capillary permeability, where you can often see the thickening and hyperreflective spaces on OCT. There's multifocal leakage on the IVFA following that petaloid pattern, and that pattern is due to the axon from the photoreceptors coursing through Henle's layer, and that kind of creates that orientation foveally. Of course, there's a variety of mechanisms and pathophysiology behind it, whether it be ischemic, inflammatory, fractional, or post-surgical. And in general, the treatment is topical steroids and NSAIDs. This is a fluorescein of the characteristic petaloid leakage. And then, the mechanisms, as we discussed, ranging everywhere from structural forms such as diabetes, where you see damage to the endothelial walls of the vessels, and hydrostatic pressure building up and occlusions and whatnot, versus inflammatory or even tractional etiologies, for which we may not even treat with drops at all, and we may actually just perform surgery to peel these membranes and relieve traction. And then also we have dystrophic causes such as retinitis pigmentosa and the retinoschisis that we also mentioned. This is an important slide. I'm sure you guys have been somewhat familiar with it, committed to memory. I can't tell you how many OCAP questions I had to answer regarding this. No leakage on FA. These are all forms and conditions that, we see, the edema, present on, but they do not leak on fluorescein angiography. So as a few examples, this patient is a diabetic, so we'll give you that. You can see the diffuse, intraretinal dot plot hemorrhages and edema is present on OCT. And so by show of hands, or you can call it out, will this patient show leakage on the FA or not? Leakage? Who votes leakage? I vote leakage. And, of course, this patient did have leakage on fluorescein angiography. All right, another example. This patient had these findings bilaterally, okay? Does anybody know first of all, what this condition is? Broad terms, retinoschisis. And so would this patient have leakage on fluorescein? Very good. Okay. So moving on to a case of 67-year-old man, he had cataract surgery in November 2018. He got better until it got worse. And then he got better again on drops. And so now he's back on the drops. He's tried stopping a bunch of times and his left eye is doing fine. He sees 20/60 out of the right eye and 20/16 out of the left. Your typical macular edema that we see on OCT and leakage on fluorescein. So this patient did in fact have pseudophakic CME, which can typically occur within 3 months post-op. And you see our highest peak at 4 to 6 weeks after surgery. It's actually pretty common, overall, as we've seen this in 25% of non-diabetic patients following uncomplicated cataract surgery, but they're usually asymptomatic and it goes away. Only about 6% of these patients actually come in with complaints of significant macular edema, whereas in diabetics, up to 50% of patients with mild or moderate NPDR and no CME actually do present with this. So meta-analysis actually showed that combination therapy of topical NSAIDs and corticosteroids did better than topical corticosteroids as monotherapy alone at preventing CME in diabetic and non-diabetic patients. Topical NSAIDs showed similar efficacy to combination therapy in non-diabetics, however. And then it's also worth mentioning that there was no significant benefit in treating diabetic patients with anti-VEGF or intravitreal corticosteroid in the prevention of CME based off this particular study. And I know there are a range of opinions on that, and some people do treat them regardless. These are the variety of topical NSAIDs that are kind of commercially available on the market. I'm not gonna go into these a bunch, but the caveat for NSAID use is that it is not without any sort of side effects. It does create a mildly anesthetic effect, and it can exacerbate surface conditions, leading to corneal ulcers, perforations, melting. And so you do kind of want to avoid them in patients who have connective tissue disease, such as sarcoid and whatnot. And then, also heed the typical kind of warnings for, patients with the, anticoagulation, and you can actually even have an asthma, NSAID-induced asthma complication. So Coates disease is typical for telangiectasias and exudative retinal detachments. It often has fusiform capillary dilations as well as venous dilations, also ectatic arteries and microaneurysms. Despite all the capillary non-perfusion that's present with Coates, the neovascularization is often rare. It's about male predominance, typically occurring in the pediatric population when it presents, and it is non-hereditary. Interestingly enough, it can have a super aggressive presentation in patients that are less than 4 years old due to the appositional nature of the exudative retinal detachments that form against the lens itself, often resembling retinoblastoma, and should be kept on the differential for leukocoria. Conversely, in slightly older kids and even adults that have late stage kind of vascular decompensation, it can present primarily as that submacular lipogranuloma, similar to what we described in type 1 MACTEL. And of course, our treatment includes cryotherapy, surgery, and photocoagulation. Speaking of photocoagulation, this is a montage photo of a patient that did present with Coates, had laser treatment. Very, very nice, kind of robust lipid exudation temporally there. And the differential is pretty vast. We mentioned the Coates-like lesions such as the vasoproliferative tumors in the forms of RP. And in cases where you don't have any exudation at all, you should keep on your differential, the typical kind of diabetic radiation retinopathies as well as RVOs. And then Also fever, ROP, von Hippel-Lindau's and forms of muscular dystrophy. There's our question. So which form of phagocytosis is non-hereditary? Who votes for neurofibromatosis type 2, ataxia telangiectasia, Sturge-Weber, tuberous sclerosis, and von Hippel-Lindau? And you guys are fantastic. Wow, very
There's a
good.
way to remember that.
So the ones like double, all the ones with double
W.
are wild, so they're sporadic.
Sturge, Weber, and Wyburn Mason. Okay.
Wyburn Mason or
So-
W also.
Anything with a W in it.
Anything with a W.
Someone said that years ago. I learned it.
Well, we're gonna focus on the ones that primarily involve the retina, and so von Hippel-Lindau is known for having the retina and CNS hemangioblastomas in the setting of visceral findings. Those visceral findings can range from the bunch of cysts that you see when the liver, kidney, and pancreas to more serious conditions like pheochromocytoma and renal cell carcinoma. And so, this always does warrant a genetic and systemic workup because some of the most common causes of death are cerebellar hemangioblastoma as well as renal cell carcinoma. We talked about the autosomal dominant inheritance, and these are mutations of chromosome 3. And I do always remember 3 because of the 3 names, if that's helpful. The hemangioblastomas are the orange red tumors that are fed by the artery and drained by the vein. It can be bilateral in 50% of these patients. They can be treated with PDT, cryo, or photocoagulation, and they're typically known as the von Hippel lesions without any systemic involvement. This is a picture of your character. This is a hemangioblastoma with both the artery and vein coming in and exiting out of it.
Let me ask you a question. If you see one of those, do you send them like soup to nuts, systemic workup, genetic testing, MRIs? What's the standard of care for that if you see one?
So I've only seen one that they had already been sent here to get the systemic workup because an optometrist or someone saw them
Spotted it.
outside. And then when they were here, they consulted us. And I thought it was gonna be this big thing that we see like
It's a
in all the
small thing.
pictures. It's so tiny.
Yeah.
And I had to like look all the way up to like try and see it. So, and this looks like super zoomed in too. So that looks like what I saw, but in the books, it's like this massive orange thing that,
Right.
yeah, so that, but that's what it looks like.
So we
but they were
rarely
here.
see them, but I guess if you see them, you ought to do genetic testing and an MRI.
Yeah.
There's a
I think
paper on
I just don't wanna miss.
Shields has a paper, there's a paper on it, I believe if there's only
You know,
one,
this low yield.
it's super
Yeah.
low, I don't think she works them up if there's, especially in old, there's also, it's an older patient. So let's say you get a older patient with only one, you have a lot to lecture, but why don't you go ahead? A really good lecture, I think a lot of work.
So Wyburn-Mason syndrome is typically known for the AV malformations. They can occur ipsilaterally, malformations involving the mandible, the jaw. These patients are the ones at risk for, as you hear about the dental extractions, they can have the massive hemorrhages. They're known as racemose hemangiomas because they lack that intervening capillary bed. And they're usually asymptomatic and outside of the full syndrome when they occur primarily inside of the retina itself. This is a picture of kind of that spaghetti type appearing lesion that you see there. I don't know if anyone does particular workup when they see this, but I think you typically would observe these overall. Retinal cavernous hemangiomas, they're usually sporadic and isolated to the eye, and they can actually have these intracranial and skin hemangiomas. And so you do want to be on the lookout for the risk of intracranial hemorrhages and seizures when patients do present with this, but they're the ones that you read about in the books as far as the grape-like clusters and the saccular angiomatous. They don't leak on IVFA, but they do have the erythrocyte layering. And we typically observe them unless they result in a vitreous hemorrhage. Again, the cluster of the grape-like appearance here, and it's very impressive and beautiful on fluorescein as well. So moving on, the last few topics here, radiation retinopathy. These patients often resemble diabetes and other retinal vascular conditions. They can have the microaneurysms, the convolutional spots, as well as the macular edema and optic nerve edema, but it's usually a delayed onset. On average, about 18 months after external beam radiation. Sometimes we can see it sooner after brachytherapy, but it does have a threshold amount of radiation to cause the clinical findings. It can have your typical ischemia and neovascularization and like some of the other diseases, we do use the anti-VEGFs and steroids for treating these patients. Valsalva retinopathy is another very common condition, at least in the retina world, where patients present with these sub-ILM hemorrhages after a increase in intrathoracic or abdominal pressure, they have a great prognosis. We usually just watch them and they do great. And, but it is important, I guess, to be careful and rule out any sort of RAM lesions, macroaneurysms, or peripheral tears, just in case.
If it's involving the, oh, sorry. No, it's okay. You were actually, I think that next photo was gonna show it, but I was just gonna ask, is there anything particular that you would do if it was involving the phobia?
It wouldn't change my management. I mean, in fact, I usually see it involving the phobia, and, you know, I've had a few cases where it may linger, where I've been on the fence as to, you know, whether or not the patient would benefit from something like a vitrectomy. But I mean, and anyone else can speak to it. I'm almost always see it get better and totally resolve on its own, so I haven't really had to do much for them.
Yeah, what I've started doing lately is if I can't decide between surgery and not surgery, I do not surgery. So it seems like this is something, I've seen people laser
They do
these.
YAG.
It's like a goofy
YAG
thing, I can't imagine YAG, it just seems,
Right.
yeah, it seems kind of nuts. People do it because you can, and people have lasers and you don't use them much, but I don't understand the reason.
Probably the reasonable risk of causing retinal problems.
Right,
Your
yeah,
YAG.
yeah, laser. So anyway,
Sometimes I see these patients and I don't know if it's a Valsalva or if maybe they have low platelets, so maybe sometimes I get a CBC.
Yeah.
You know, they can look, cause sometimes it's not so obvious where there's a bunch of them, it's just, there's one lesion.
Is there any role for like pneumatic to like displace the?
well, it's pre-retinal, so it's benign, so yeah, you wouldn't mess with it.
Is sub-ILM and pre-retinal the same thing?
Yes.
Yeah, so sub-ILM counts as pre-retinal, I think, if you ask most retinists, but.
Sub-ILM.
Yeah, sub-high, it's kind of sub-hyaloid more than sub-ILM. It's hard to tell sometimes, but it's sub-hyaloid.
So Purtscher's retinopathy, we see typically these cotton wool spots, and then also these flecking areas, which are wedge-shaped areas of retinal whitening that are slightly deeper, at a deeper layer than the cotton wool spots. And the thought is that there's non-perfusion of the radial peripapillary region of some of the capillaries involving that area, and that's where we see the cotton spots that tend to kind of course over our retinal vessels versus the flecking that kind of goes under the retinal vessels and is more kind of circumscribed in nature because it involves a deeper kind of radial laminar region of the capillaries themselves. Usually associated with compression injuries to the head or thorax, resulting in vision loss. This does trigger a complement cascade where we see aggregation of the granulocytes that also lead to leukoembolization. And in the absence of trauma, it is technically classified as Purtscher's like, and so you do, and often, you know, most patients honestly don't present with the characteristic trauma. So I find myself often working out these patients for things like pancreatitis and lupus as well, and that's how we notice it. Again, beautiful photo of Purtscher's retinopathy with the optic nerve head swelling, as well as mixture of those with some cotton wool spots nasally and hemorrhages as well. Then last topic, Turson syndrome, kind of similar pathology. Intracranial pressure can cause an acute rise in intraocular venous pressure, which causes the capillary to rupture. Those different layers we talked about that can be involved, and about a third of patients with subarachnoid hemorrhage or subdural hemorrhage do develop the intraocular hemorrhage, and it's also supplemented with good prognosis. Thank you, guys.
That was actually